Hello, and welcome to CIOMR's Virtual Combat Casualty Care, or CCC, training programme. I'm Hannah, and it's my pleasure to be your guide. CIOMR thinks CCC training to be indispensable for all military personnel because we know from experience that the sooner care is provided when something bad happens, the better the chances for survival and recovery are. In that respect, the buddy is just as important as the medical service. For that reason, the CIOMR has presented a CCC competition for some 45 years. Since 2003, we followed the so-called Tactical Combat Casualty Care, or the TCCC guidelines. Those guidelines were first published in 1996 by and for the US Navy Special Forces medics. TCCC became extremely popular in the military medical world, and the armed forces of many countries sort of adopted them. So did CIOMR. CIOMR has produced its own manual in 2003 because not all countries accepted all details of TCCC, and for a competition it is necessary to have a level playing field. The ins and outs of that competition, how it is built, and how it is scored are available on CIOMR's website. In 2018, COMEDS, the highest medical advisory body in NATO's military committee, stated that all pre-hospital care in NATO should be TCCC based, and a year later the TCCC guidelines for all service members were published. CIOMR has reviewed and revised its CCC manual accordingly, as is done every 6 months. The training programme consists of 3 parts: self-study, e-learning, and a test. Hopefully you have already downloaded the manual and you have also watched the technical videos. In this e-learning session, we'll go through the manual step by step, showing you slides are based on the text of the manual. It is useful to have the manual at hand, in particular the algorithm that shows you how things are related. But in this voiceover, we'll provide comments and explanations. Basically, it is a repetition of the material you have already studied. Every now and then, self-assessment questions will appear. At the next click, you'll see what we think is correct and where in this programme or in the manual you can find that information. Here we go. First of all, ideally, you're working as a team. Make certain you've chosen a team leader, that you've assigned tasks beforehand, and that you know your equipment. Then always be aware of the conditions you're in. The question is, are you under fire/threat? Is the situation semi-permissive or permissive? If you're under fire or threat, your own safety comes first. Casualties will have to fend for themselves to begin with. If possible, they should get under cover and help themselves. You can only go to help if your commander on the scene permits you to do so. You do what is necessary and feasible to get the casualty to a safer place.
In this phase, the scene is unsafe, and you must take tactical considerations into account. If still under enemy fire, you should first return fire and take cover. If they are able, direct the casualty to remain engaged as a combatant as well. In addition, direct the casualty to move to cover and apply self-aid if possible. If the casualty is not responsive or unable to move, assess the tactical situation for the best options to move the casualty or secure the site. Perform a casualty drag or carry to move the casualty to cover. Casualties should be extricated from burning vehicles or buildings and moved to places of relative safety. Do what is necessary to stop the burning process.
When you and the casualty are under active enemy fire, the only help you can give is to stop massive bleeding using a tourniquet. If it is obvious the casualty doesn't react, you turn them on their belly to help them breathe. And that's it.
In this phase, the scene is unsafe. Stop life-threatening external hemorrhage if tactically feasible by applying a limb tourniquet to control life-threatening external bleeding. Apply the limb tourniquet over the uniform clearly proximal to the bleeding sites. If the site of the life-threatening bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible on the injured limb, and move the casualty to cover. A tourniquet is the only hemorrhage control option that should be used in care under fire. Once no longer under enemy fire, tactical field care can begin.
Hey, it's Kurt. We're going to talk about the Combat Application Tourniquet, or CAT. Important thing to remember is this should be always accessible on your kit, not buried in a pocket or somewhere not accessible when you need it. First thing you want to do is take the tourniquet, wrap it around the patient's extremity as high as possible. Take the strap, tighten it as tight as possible so 3 fingers cannot fit under the strap itself. Secure the strap using the Velcro. Take the tightening rod, twist until bleeding has stopped. Secure the rod into the securing clip. Check the pulse to make sure you have cut off the blood. Secure the strap through the securing clips and place the safety strap across the rod. Remember to annotate the time of application.
If you're not or no longer under fire, you can start tactical field care. Be aware that the situation may change for the worse. Let the higher echelon know that you have a problem, and be aware of your own safety. Set up a parameter and wear gloves.
From anyone who is not alert and fully oriented.
Make certain you remove weapons and comms equipment. If there's more than one casualty, you'll have to triage. This is the formal way. If you're in a hurry, think of this. The person who shouts is definitely alive. Turn to the quiet one first. They may have no injuries at all, or they may be dead. But actually, in fact, they may be unconscious and in need of help. Each casualty should be assessed. We use the acronym MARCH.
Establish a security perimeter and maintain tactical situational awareness. Triage casualties as required. Remove weapons and communication equipment from casualties with altered mental status immediately.
As soon as possible, maybe even before you have moved the casualty to a safe area, check for responsiveness by communicating with the casualty to determine if they are awake, and if so, if they are confused or disoriented. Hey buddy, you okay? In a combat situation where your casualty is armed, you should take all weapons and radios from anyone who is not alert and fully oriented. A confused or disoriented casualty may resist being disarmed, so say something like, "Hey buddy, let me take your weapon while I check you out."
We use the acronym MARCH, with M standing for massive bleeding. Sometimes you see the blood spurt, sometimes there's a lot of blood on the ground. If that is not the case, don't forget to pat down the casualty. Stop the bleed from the limbs with a tourniquet
First, sweep the front and back of the neck, then stop and look at your hands for traces of blood. From the neck, move down to sweep each arm, including the armpit, one at a time, stopping every few inches to look for signs of blood on your hands. When performing a blood sweep, use your fingertips. This will assist you in finding penetrating wounds as well as be effective in low light conditions. Continue to sweep each leg, including the groin, again stopping every few inches to look for signs of bleeding.
If not already done, use a CCC recommended limb tourniquet to control life-threatening external hemorrhage. If bleeding is not controlled with the first tourniquet, apply a second tourniquet side by side with the first. For compressible hemorrhage not amenable to limb tourniquet use, use one of the approved CCC hemostatic dressings.
Stop the bleed. From elsewhere, the trunk, the neck, the head, with dressings and pressure.
Hi folks, Zach here. We're going to be going over wound packing today. The Committee on CCC approves 3 types of hemostatic gauze: combat gauze, Celox gauze, and Chita gauze. Once you have identified a wound, hold pressure, direct pressure, and expose that wound. Go ahead and try to identify the major bleeder or any other bleeds within that wound. We're going to hold pressure on that wound. Open up your combat gauze, make a small ball. 1 for 1, replace the finger that's holding pressure against the bleed until you've packed that entire cavity. Again, 1 for 1, maintaining pressure while you're packing and ensuring that blood isn't seeping through or around the combat gauze as you're packing it. You're going to continue to pack, maintaining pressure the entire time you're packing. Once you've packed the entire wound, hold pressure over the wound, ensuring that blood isn't seeping around or through the combat gauze. Hold pressure for 3 minutes. Once the 3 minutes is up, and it's time for a pressure dressing. Hi folks, Zach here. We're going to be going over pressure dressings. The pressure dressing that we're going to be using today is the emergency trauma dressing commonly found in the IFACs within the Army. Once you have the wound packed, again, we're going to use the 1 for 1 replacement here. So I'm going to maintain pressure using my thumb, any other digit that I can, and then I'm going to expose the sterile portion, which looks like this. Place it over the combat gauze, and as I wrap, maintain pressure, being sure that I don't pull the combat gauze off of the wound, out of the wound, and being sure to lock in the sterile field that's over that combat gauze. Short tugs to ensure that we're tight. Until we get to the Velcro portion of the emergency trauma dressing. There's a locking mechanism on this dressing. Once we've Velcroed, we want to pull up a portion of the wrap and secure it in place with these teeth. That completes pressure dressing.
Right, now we focus on A, airway. It is somewhat complex, but it can be done. When we start helping, we talk, so we know whether the casualty is reacting or not. The casualty who does not react when you shout has a different approach, because they might be deaf due to ruptured eardrums, or unconscious due to a brain injury or severe blood loss, or they may be dead. In the unconscious casualty, we always look whether there's something in the mouth and remove it. Then we open the airway and check whether the casualty is breathing normally, i.e. whether there is passage of air. If you can hear and feel that the casualty is breathing, you know that they are alive. An unconscious casualty lying supine will get trouble with their airway. So you make certain the airway remains open by the measures you see on the screen. In an unconscious casualty, this concludes assessing the airway and treating obstructions. Consider whether the neck must be immobilized. In the military, we immobilize the neck only when it's tactically feasible, and only in casualties with blunt trauma. A casualty with penetrating injury of the neck who is moving all limbs doesn't need immobilization. Consider this whenever you're done assessing A, and then you go on with R, respiration.
If unconscious, use a head tilt, chin lift, or jaw thrust maneuver.
Use the chin lift or jaw thrust maneuver, or nasopharyngeal airway. The recovery position helps to protect against vomiting and aspiration. Cervical spine stabilization is not necessary for casualties who have sustained only penetrating trauma.
If an unconscious casualty is still not breathing after opening the airway, and you're not in a permissive or occasionally a semi-permissive environment, that casualty is beyond help. Maybe a medic can do something, but only occasionally. Basic life support, CPR, is only to be considered in a passive environment. If it's decided to perform CPR and it is successful, which is very rare, you will hear and feel that the casualty is breathing again. Then you should go on with R, respiration.
Okay, so far I've been talking about the unresponsive casualty, the casualty who does not react. From here I'll discuss the responsive casualty, the person who does react when spoken to.
If they are reacting, they are conscious. When the casualty replies to your questions, you can listen to their voice, and when the voice is clear, you know that the airway is open. You can go on with R, respiration. Before doing that, consider whether the neck must be immobilized. If the casualty reacts and the voice is not clear, there must be some sort of obstruction. You will have to address that. A casualty who has an obstruction of their airway and who is conscious usually wants to sit up. If it's tactically feasible, you should allow that. Have a look in the casualty's mouth and remove any obstruction. Whether or not to insert an MPA depends on the regulations of your country. We mention it, but it isn't obligatory. In a conscious casualty, this concludes assessing the airway and treating obstructions. Having done that, you think whether the neck should be immobilized, and then you go on with R, respiration.
Airway management. For a conscious casualty with no airway problems, no airway interventions are needed. For the conscious casualty with airway obstruction or impending airway obstruction, allow the casualty to assume any position that best protects the airway, to include sitting up. Again, use chin lift or jaw thrust and use suction if available and appropriate. The nasopharyngeal airway is well tolerated by a conscious or unconscious casualty without stimulating the gag reflex and provides some protection of the upper airway.
Good, you've made certain that your casualty is alive and breathing, but that doesn't mean that respiration is normal. If the casualty is breathing too slowly, they may have a serious head injury. If they're breathing too fast, look for an open chest wound and seal that. Also look at the back. If the casualty doesn't improve after sealing the wounds, you can try to lift an edge of the seal.
In a sucking chest wound, also called an open pneumothorax, air enters the pleural space through a wound in the chest wall. The lung deflates and pulls away from the chest wall. Air now enters the chest through the hole instead of into the lungs. It usually takes a hole in the chest the size of a nickel or bigger for this to occur. Treat by applying a vented occlusive dressing completely over the defect at the end of exhalation, because at this point in the breathing cycle, there is relatively less air in the pleural space. If the wound is completely occluded with a non-vented dressing, air can no longer enter or exit the pleural space through the wound in the chest wall. If signs of a tension pneumothorax develop, lift one edge of the seal and allow the tension pneumothorax to decompress, burping the seal. Alternatively, remove the seal for a few seconds to accomplish the decompression, then reapply.
Hi everyone, I'm Joe. Today I'm going to be talking to you about the application of a vented chest seal and an occlusive dressing, and also we'll be going over how to burp the occlusive dressing. Step 1, we're going to inspect the thorax. Once you notice that there's a thoracic injury, peel open our occlusive dressing and remove it from its package. And if you have a 2x2 or Curlex, wipe away the blood away from the side of the injury. Apply the vented chest or occlusive dressing upon exhalation. Reassess. Be sure to log roll your patient and check for a downside wound. Inspection of a downside injury, wipe the area away, and apply an occlusive dressing. For demonstration purposes, I'm going to be applying the occlusive dressing on the downside injury. And again, apply upon exhalation. And reassess. And that concludes the application of the vented chest seal and the occlusive dressing. Now we're going to talk about burping the wound. Upon reassessment, if you notice any clots formed or any increase in respiratory difficulty, to burp the wound, simply peel back the chest seal, clear any clot away from the area, and reapply the chest seal upon exhalation.
Assessing C, circulation. This covers 3 subjects, which, as you will see, all have to do with bleeding. In the field, ongoing bleeding is one of the main causes of death. First, check whether tourniquets have been applied in a hurry and are still effective. Has the bleeding not stopped? Can you still feel a pulse at the wrist or at the ankle? If so, the tourniquet is no longer effective and needs to be tightened further, or you may have to apply a second tourniquet alongside the first. During care under fire, a tourniquet may have been applied high and tight over the uniform. If so, the wound should be exposed and the new tourniquet moved to an appropriate 3 inches or 7 centimetres proximal to that wound. This manoeuvre is not made if the casualty is clearly in shock, or if the tourniquet was applied for a traumatic amputation. Make certain that the tourniquets always remain visible, and check whether the time of application has been noted on the tourniquet or on the casualty's body.
Reassess the prior tourniquet application. If bleeding persists or a distal pulse is still present, consider additional tightening of the tourniquet or the use of a second tourniquet next to the first to eliminate both bleeding and the distal pulse. Do not loosen the tourniquet intermittently to allow circulation to return to the limb. Expose the wound and place a second tourniquet 2 to 3 inches above the wound. Loosen the first tourniquet while watching for continued bleeding control by the second tourniquet. Check to make sure the distal pulses do not return. Do not ever apply it and forget it.
The next thing to do is to check whether the casualty is in shock. Shock has many causes, but in trauma it is usually caused by considerable blood loss. Shock is a very serious condition that can quickly become fatal. Shock must therefore be recognised and treated. You can prevent shock from getting worse by stopping bleeding as good as you can, and the medic can try to replace the blood loss with IV fluids. The signs and symptoms are mentioned in the slide. Please look for them and get help from a medic.
Shock is inadequate blood flow to the body tissues. Shock can have many causes, but on the battlefield it is typically caused by severe blood loss. Hemorrhagic shock is a leading cause of preventable death on the battlefield. Is to not let them lose this much blood. Remember, the most reliable signs of shock on the battlefield are a decreased level of consciousness without TBI and/or a weak or absent radial pulse. If signs of shock are present, control the bleeding first.
As I said, shock is bad. Blood loss causes shock, so blood loss should be stopped the best we can. We already worked on that during massive bleeding, but now it is time to look for all external wounds that are bleeding. Expose them and deal with them. Applying a tourniquet at this stage seldom happens, but everything is possible. Blood loss may also occur internally, which is difficult to treat in the field. A broken limb should be splinted, and this will be addressed later. Internal bleeding in the trunk makes transportation to a surgical facility very urgent. For H, we have hypothermia and head injury. The problem of hypothermia is that blood no longer clots, something you don't want to happen in an injured casualty. Prevention of hypothermia, which develops very quickly in trauma victims, is essential. There are excellent kits on the market, but simple measures can be helpful too.
Preventing hypothermia is extremely important for the casualty. It's not just about keeping them warm. It may also save their life. Casualties can become hypothermic, which worsens bleeding. To prevent hypothermia, minimize the casualty's exposure to the elements and keep protective gear on or with the casualty if feasible. Replace wet clothing with dry if possible. Get the casualty onto an insulated surface as soon as possible. Apply the Ready Heat blanket from the Hypothermia Prevention and Management Kit, or HPMK, to the casualty's torso, not directly on the skin, and cover the casualty with a heat reflective shell, or HRS. If an HPMK is not available, the combination of the Blizzard Survival Blanket and the Ready Heat blanket may also be used. If nothing else is available, use dry blankets, poncho liners, sleeping bags, or anything that will retain heat and keep the casualty dry. Prevent hypothermia before it happens.
Head injury is often obvious. An unconscious casualty with wounds to their head. Sometimes damage to the brain is subtle, for example in blast injuries. You have to look for symptoms and signs as mentioned in the slide. They may point to serious trouble, and if you can find them, you should report them. There's no treatment that you can do in the field. Okay, this concludes March. What to do next to get the casualty off the battlefield? That's clearly outlined in the manual, and so we need not go into detail. On the other hand, there are several items that need some extra comments. Different countries have different approaches. Soldiers may carry a pill pack to take medications themselves. In other instances, that is the medic's job. Medications play an important role. Severe pain is not only unpleasant, it is also damaging for the body and may worsen outcomes, including the development of PTSD. Antibiotics may be helpful in preventing infection, the big complication of war wounds. All major eye injuries should be evacuated. Don't remove foreign objects or what looks like a blood clot. The latter may be part of the iris that bulges out through a perforation of the eye. Cover the injured eye with a rigid shield or something improvised. The point is to not exert pressure on the eye. Don't apply a dressing. One of the big problems for casualties with burns of the face is inhalation injury, a burn of the airway. There's little you can do in the field, apart from allowing the casualty to take a position that is comfortable and get help from a medic. Burns should be cooled, but be aware the casualty can become hypothermic. Fractures are painful and they bleed internally if the skin is intact. Blood loss may be significant, in particular if there is also a wound. Covering wounds and straightening the broken limb will diminish blood loss, but if possible, you should give pain relief before you start manipulating. Once the limb has been straightened, a splint should be applied. Always check for pulses before and after putting on the splint. If pulsations were present before and they have disappeared after manipulation, you should loosen the splint. And finally, every wound that needs to be dressed should get that dressing. Communication is extremely important. That goes without saying. Calling for evacuation should be done as soon as you have the relevant data. The 9-liner is the standard of today, and it is a series of numbers and letters. There is no need to remember what is what. Always use a template. The condition of a casualty may, and usually will, change over time. It's extremely important to re-examine the casualty until they can be evacuated. Treat whatever new problems come up as far as you can. During evacuation, the casualty will pass through a number of medical treatment facilities. They need to know what was found and done in the field. Unfortunately, we know from experience that the information is often incomplete or missing. Please write your findings and treatments on a casualty card and attach that to the casualty. That too may make the difference. Correct positioning may make things more comfortable for the casualty. The usual position during evacuation is supine on a stretcher, but there are exceptions that should be taken into account. During the evacuation, there should be no loose ends, because one thing is certain, what can get loose during transportation will get loose. The handover should be concise and clear. Using the acronym ATMIST is helpful. Okay, now for a demonstration at speed.
Hi, I'm Abby. I'm an active duty 68 Whiskey combat medic. I will be showing you how to perform a tactical trauma assessment. It will follow the march sequence. The first part of the tactical trauma assessment occurs in the care under fire phase. In this phase, the scene is unsafe, and you must take tactical considerations into account. If still under enemy fire, you should first return fire and take cover. If they are able, direct the casualty to remain engaged as a combatant as well. In addition, direct the casualty to move to cover and apply self-aid if possible. If the casualty is not responsive or unable to move, assess the tactical situation for the best options to move the casualty or secure the site. Perform a casualty drag or carry to move the casualty to cover. Casualties should be extricated from burning vehicles or buildings and moved to places of relative safety. Do what is necessary to stop the burning process. In this phase of care, stop life-threatening external hemorrhage if tactically feasible by applying a limb tourniquet to control life-threatening external bleeding. Apply the limb tourniquet over the uniform clearly proximal to the bleeding sites. If the site of the life-threatening bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible on the injured limb, and move the casualty to cover. A tourniquet is the only hemorrhage control option that should be used in care under fire. Once no longer under enemy fire, tactical field care can begin. First, establish a security perimeter and maintain tactical situational awareness. Triage casualties as required. Remove weapons and communication equipment from casualties with altered mental status immediately. Next, reassess for massive hemorrhage, the M in March, and control all sources of bleeding. If not already done, use a CCC recommended limb tourniquet to control life-threatening external hemorrhage that is anatomically amenable to tourniquet use or for any traumatic amputation, applied directly to the skin 2 to 3 inches above the bleeding site. It is important that if the bleeding is not controlled with the first tourniquet, apply a second tourniquet side by side with the first. For compressible external hemorrhage not amenable to limb tourniquet use, apply a CCC recommended hemostatic dressing. You can apply a hemostatic dressing with direct pressure if a junctional tourniquet is not available or while the junctional tourniquet is being readied for use. The next step is airway, the A in March, during which you must assess and secure the airway. Allow conscious casualties to assume any position that best protects their airway, to include sitting up. If unconscious, use a head tilt chin lift or jaw thrust maneuver. In addition, insert a nasopharyngeal airway in an unconscious casualty without airway obstruction and place them in the recovery position. The next step is respirations, the R in March, where you must assess respiration. First, apply a chest seal to any open chest wounds. Next is circulation, the C in March. You must reassess prior tourniquet application and again after each movement of the casualty. You must also assess for hemorrhagic shock as noted by altered mental status in the absence of brain injury and or a weak or absent radial pulse. The H in March stands for head injury and hypothermia. If the patient is at risk for hypothermia, you should prevent hypothermia by minimizing the casualty's exposure to the environment and employing active heating measures. If there's a suspected head injury, you must assess and document the mental status using the AVPU scale. After following the March sequence, there are several other additional treatments that should be performed. If the casualty is conscious and able to swallow and has mild to moderate pain, or if the casualty is still able to fight, administer the oral analgesic from the combat wound medication pack. If there is moderate pain to severe pain and the casualty is not in shock, refer to a medic. If the casualty is conscious and able to swallow and has an open wound, including all penetrating injuries, administer 400 milligrams of moxifloxacin, the oral antibiotic from the combat wound medication pack. If the casualty cannot swallow due to shock or is unconscious, refer to a medic. You must treat all combat wounds, inspect and dress all known wounds, assess and treat burns by applying dressings to burns, and be sure to check for additional wounds such as scalp lacerations and other wounds that may be hidden by clothing or equipment. If a penetrating eye injury is noted or suspected, cover the eye with a rigid eye shield and administer 400 milligrams of moxifloxacin from the combat wound medication pack. Splint any fractures found on the casualty, as splinting of fractures can result in significant pain relief and minimize bleeding. Make sure to document all assessments, treatments, and changes in status on a TC3 card. Once the tactical trauma assessment is complete, you must prepare the casualty for evacuation by performing the following steps. Complete and secure the TC3 card, the DD 1380, to the casualty. Secure all loose bandages, equipment, blankets, etc. Secure your litter straps as required. Consider additional padding for long evacuations. Provide instructions to ambulatory patients as needed. Stage your casualties for evacuation and identify litter teams. And finally, always maintain security at the evacuation point. And always remember to reassess your casualty to make sure their condition has not changed and the treatments used remain in place and effective.
Well, this concludes the e-learning. I hope you've enjoyed,